Well, it's a great pleasure for me to introduce Stephen Dean. I personally invited him because I think the whole field of lymphedema is under-taught and we don't understand it as well as we should. And he came to our lecture series in Chicago for a number of years. So this is the first time we've been able to get him to the West Coast for for TED anyway. And I thank you for coming. He works at Ohio State, and he's one of the country's biggest, the most knowledgeable about lipedema and lymphedema. So there's a lot to learn here. Thank you for coming.
Oh, Patty, thank you so much. All right, we could just stop right there. There's what lipedema is, that picture right there. Oh, okay, there we go. It's going. Is this a trick? Okay, thank you. Okay. All right, minimally relevant disclosure. We're not going to be talking about exact treatment options from a pump standpoint. But anyway, I don't know how many have read this 2021 article on the standard of care for lipedema in the U.S. There were over 70 consensus statements, and I think by far the most compelling is statement 1.1. And that is lipedema should be regarded as a loose connective tissue disease versus a disease of just adipocytes or fat. Keep that in mind as we go through some of these manifestations. So all the way back in 1951, Dr. Wold and Associates at Mayo Clinic released this seminal article on lipedema. And at that time, they identified 6 cardinal features of lipedema, which have remarkably stood the test of time. Number 1, 99.9% almost exclusively female. Number 2, bilateral and symmetrical with sparing of the feet, at least in classic lipedema. A component of minimal dependent orthostatic pitting edema at the end of the day, hence the term lipedema. Very important point, over 90% of these patients have significant pain and or cutaneous hypersensitivity. In fact, the Europeans will say, if you don't have pain or cutaneous hypersensitivity, you do not have lipedema, rather lipohypertrophy. Up to 80% of these patients have a tendency to easy bruising, and finally, persistent enlargement of the extremities even after profound weight loss. So there's a very unique somatotype to the patient with lipedema where the torso is spared, the feet are spared of this disproportional excessive symmetrical fat deposition. There's a mismatch between the size of the torso and the lower extremities, as you can see here. There's a pear-shaped configuration to the body. I'll draw your attention to the top part of that arrow. There's a longitudinal cicatrix you can see there. That patient was told she was grossly overweight, got to lose weight. She lost 100 pounds to gastric bypass surgery. Her legs still look like this, leading to the adage, you can't starve lipedema. So I think it's worthwhile comparing and contrasting the classic features of lymphedema seen on the left versus lipedema on the right. Lymphedema can be unilateral, it can be bilateral. Lipedema, by definition, is always bilateral. Lymphedema, even when it's typically bilateral, as you see here, there's usually some asymmetry versus lipedema tends to be relatively symmetric. I mean, nothing's perfect, but again, it's usually relatively symmetric. And then finally, lymphedema is typically, although not invariably, associated with significant foot and toe swelling as seen there, versus a lipedema patient where the feet and toes are spared of swelling. So a very good contrast there between these sets of legs. Another unique phenotype of the patient with lipedema is the ankle cuff sign, where this disproportionate symmetric fat deposition abruptly terminates just above the level of the malleoli, as you can see in these 2 nice examples. Another helpful phenotype is the lateral malleolar fat pad sign, where you get this protuberance of fat along the lateral malleolus. I find this very helpful in some of your early lipedema cases where you're not really sure, is this classic lipedema? This tends to be an early feature, so look down at that lateral malleus and see if you can see a protuberance of fat. Very, very helpful. As I said earlier, up to 80% of these patients have a tendency toward easy bruising, as seen here. And why would that happen? Well, it's a loose connective tissue disease, and these capillaries are residing within a bed of dysfunctional connective tissue, which leads to capillary dilatation, tortuosity and friability, and ultimately bruising. In fact, when you look at the recent Vanderbilt study of over 700 lipedema patients, a patient with lipedema was 26 times more likely than a weight-matched cohort to have easy bruising. So it's the real deal there. Here are the stages of lipedema. Stage 1, where the skin is smooth. Stage 2, where you start to get a nodular appearance, which has been likened to a mattress or a waffling appearance. Looks like cellulite, basically. And then finally, stage 3, where you get these big overhanging lobules. That's a good progression there between 1, 2, and 3. Here are the various lipedema phenotypes. We'll go through these 1 through 5. As opposed to having to memorize all of these 5 types, I like the European approach. It's a little bit more descriptive. And they simply say, if it affects the legs, it's the upper legs, it's the full leg, it's the lower leg. And there's similar breakdown when it comes to the arms. You'll find that the majority of these patients are a full leg type and an upper arm type. I'll show you some examples here in subsequent slides. So here is the most common lower extremity phenotype, the full leg type, where this disproportionate symmetrical fat deposition begins in the hips and it terminates at the level of the malleoli, also known as a type 3. Again, that's the most common you're going to encounter. Second most common is going to be a type 2, or the upper leg type, where this symmetrical fat deposition begins in the hips and terminates at the level of the patellae. Pretty good examples on both of these. I'd call these both the stage 3, by the way, because of the overhanging fat lobules there. And this is a really rare subtype, the type 5, which is just infrageniculate in distribution. I don't see many of those. This was a remarkable case, actually. This was a marathon runner, and you can see her, despite being a marathon runner, you don't see any definition of her calves. I mean, as she said, I've had cankles all my life. This is a cankle subtype. And although when you see these patients are typically complaining of leg swelling, if you do a careful examination, you'll find that 80% of them also have involvement of their upper arms. And it's usually of the upper arm type, where it begins in the shoulder and stops at the elbows. And these are referred to as bat wing or angel wing deformities, very, very common. A little less common is the full arm type, where that fat distribution goes all the way down to the wrist, culminating in a wrist cuff sign, which is analogous to that ankle cuff sign that I showed you in the lower extremities. And what you're typically going to see, this is your most common phenotype. It's an amalgamation of the full leg type and an upper arm type. That's usually what you're going to see if you do a careful physical examination on these patients. Look at them. I don't know if I can go back here. See if I can go back. Then I go back. Okay, look at that one on the right. You don't see any fat in her torso at all. Isn't that remarkable? But yet she still has a early stage 3 or lobular subtype. She exercised a couple hours a day. It was really, really sad. Now, with the passage of time, and especially in the setting of obesity, your patients with lipedema can develop secondary lymphedema, also known as lipolymphedema. And note the amount of foot swelling you see there. It's usually very modest. It's not what you see in your primary lymphedemas, where you get that big curvaceous buffalo hump, but you can get a little bit of fixed foot swelling as opposed to orthostatic foot swelling. Varicose and spider veins often complicate lipedema. In fact, in this series, it occurred in up to 100% of these patients. Not exactly surprising when you figure this is a connective tissue disorder. I mean, Marfan's patients will have lipedema. Ehlers-Danlos will have lipedema. Loeys-Dietz, connective tissue disorder. And also, patients with lipedema can develop chronic venous insufficiency, although grossly underreported in the medical literature. In fact, data from my institution, we identified that half of our patients with lipedema also had concurrent chronic venous insufficiency. And this is important if you're doing vein work for the following reason. Up to 1 in 4 of these patients will have a refluxing great saphenous vein. And of course, the patients will wonder, they may or may not, will they benefit if you ablate their great and or small saphenous veins? I'd be very careful about this and realize that lipedema is the predominant cause of the limb swelling and pain. It's not a refluxing vein. I've seen so many unhappy lipedema patients that have undergone, believe it or not, bilateral great and small saphenous vein ablations, and not surprisingly, their leg pain never improved. You may see some modest improvement in their pain, the orthostatic edema, but it's not going to do anything for the size of that leg. So how do you treat these patients? A couple of slides, and we'll terminate here. Manual compression, sequential pneumatic compression pumps, compression garments, nothing unique here. With the caveat is because of the associated cutaneous hypersensitivity and pain, a lot of times these patients don't tolerate a lot of pressure. You're lucky just to get a 15, 20 millimeter stocking on them. And as seen here in these 2 consensus statements, lipedema reduction surgery is currently the only available technique for removing this dysfunctional fatty tissue. That's it. It's very, very effective at reducing their pain scores, statistically significant improvements in walking, quality of life, weight loss, and even stage reversal in a minority. But at the last slide here, problems with liposuction for lipedema is mainly insurance denial. Insurance companies consider this a cosmetic problem, which is unfortunate. And then there are a very limited number of plastic surgeons out there that actually have expertise in lipedema. And then even when they do reimburse it, there's some of these surgeons are disincentivized because the reimbursement is so nominal. So I'll leave you with this, and thank you for your attention.
Thanks.